Hello and good afternoon, everybody. Welcome to Facebook Live. So, today is World Parkinson's Day, that is 11th April, and it is our pleasure to celebrate it and to discuss about this very important disease which has affected millions globally. And it has been termed that coming years and decades it will be called the Parkinson's pandemic, with an exponential rise in the patients by 2040. Almost the number of the patients would double. So I welcome my esteemed colleagues, Dr. Vivek Agarwal, consultant neurosurgeon at Reliance Foundation Hospital, Mumbai, and my co-colleague, Dr. Ishu Goyal, consultant neurologist at Reliance Foundation Hospital in Mumbai. So I welcome my colleagues. So let us start. So I would start by asking Dr. Ishu. Dr. Ishu, can you tell us what is Parkinson's disease, and how does one know whether he or she has Parkinson's disease? Can you enlighten us about it?
Yeah. Good afternoon, everybody. I'm glad I have the opportunity to speak on this topic today. So, Parkinson disease is a neurodegenerative disorder. In fact, it is the second most common neurodegenerative disorder after dementia. To put it in a simple terms, because everybody might not understand what is a neurodegenerative disorder, in this disease, there is a deficiency of a certain chemical in the brain, which is called as dopamine. And this dopamine is continuously released in our brain, and it facilitates and it ensures that whatever body movements are happening, they happen smoothly. The movement should not be less, the person should not be very slow, and the movement should not be very excessive. So all this regulation of motor activity is done by the chemical called dopamine, which becomes deficient in Parkinson disorder. Then subsequently, as the person ages and the disease progresses, the nerve cells keep on dying, and then there's a toxin that keeps on accumulating within the brain, which gradually makes the person immobile, leaving him with a lot of disability. So, kept in short, this is what is Parkinson disease is all about. So, the cardinal features of Parkinson disease. The next question was like, how do we know whether the person has
Yes.
Parkinson's disease or not? So, usually we see that in earlier stages, the person does not come to know about it because usually it starts on one side of the body. So, if right side is involved in the earlier stages, the person still might understand that something is wrong with his body. He's not able to use his right hand very effectively. The movements that he was able to do earlier, like signing, or in case of females, cutting vegetables, cooking, and all, have are becoming progressively difficult and difficult. Then they may come in early. But if it is the left side that is involved, usually many years go by and patient do not realize that they have any difficulty. So the early signs of Parkinson disease, which one might be watchful about, are any kind of slowness of movement. The a thing that you were able to do speedily before, it is taking a lot more time than before, is one thing. Then many a times other people point out that the way you are walking is somewhat different. Earlier you were able to take proper strides and the speed of walking was good, and now it is difficult for you to catch up with us. You are taking small baby steps to walk. So these kind of changes in walking pattern are also one of the very important features of Parkinson disease. And the third important thing is the shakiness or the tremors of the hands or the legs. Usually it starts in the hand, and usually one side of the body is affected, as I said earlier. So if there are shaking and your handwriting is changing, the way you used to sign your checks, if on any occasion the check gets bounced because the sign did not match, and somebody notices that while sitting when you're watching television and your hands are shaking, so that may be indicative of Parkinson disease. So the shakiness
Right.
or the tremors of Parkinson are generally seen at rest. So you might think of PD when all these symptoms come to the notice of a patient. So,
Right.
Dr. Manish, I would like to ask you that what are the causes of Parkinson disease? Like, is it acquired or is it genetic? And like, who are predisposed to get Parkinson disease?
Yeah, so Parkinson's disease can be a genetic disorder. I mean, especially when we see Parkinson's starting at young age, what we call young onset Parkinson's disease. There are certain genes which are attributed to cause Parkinson's disease and associated symptoms. Some patients may have tremors, some may have rigidity, some may have some other features along with Parkinson's disease. So genetic definitely is there. It may run in families, not necessarily that every patient may have a familial history, but definitely Parkinson's disease runs in families. So this is a group which we call young onset Parkinson's disease, which we see in the 20s and 30s and 40s. The other Parkinson's, which we very commonly see in our clinic in day-to-day practice, is Parkinson's happening in elderly patients, which is because of aging. As Dr. Ishu has rightly said, it's a neurodegenerative disease. So neurodegenerative disease as a group of disorders can is seen mostly in elderly patients. So aging definitely can cause degeneration of those particular areas of the brain, especially ones which release dopamine and the associated chemicals which cause Parkinson's disease. Among the other things, besides genetics and aging, certain environmental factors which the person faces during his lifetime, like the hypothesis about pesticides, herbicides, some industrial pollutants, some medications which the patient may take during his lifetime, like patients may be on certain type of antipsychotic medications for some other indications if they have taken for a long term, certain other medications used for certain gastric disorders like indigestion and all. I mean, I will not go into the details of them, are also known to predispose to Parkinsonism or Parkinson-like features. What medications I was speaking of is called a group of disorder called tardive Parkinson's disease. So environmental things which the patient faces during his lifetime, aging, genetics, all have been attributed on a case-to-case basis. What the patient asks us why he has got Parkinson's disease, accordingly we guide the patient and tell them that of course this may be the reason for your symptoms and the Parkinson's disease that he has got. So, Dr. Ishu, I would like to ask that once I say Parkinson's disease and you have told me the clinical features, how is it diagnosed? How do I confirm that patient has Parkinson's disease?
So the diagnosis of Parkinson disease is mostly clinical only. So majority of the cases are diagnosed on the basis of clinical symptoms, the way they present, the signs that we get in the examination, and then when we decide that this may be a Parkinson disease, and when we start with the medication, if the patient responds to the medication, that itself confirms our diagnosis that yes, it is Parkinson disease. But when a person comes to the clinic, we do apply certain criteria, the most important one and the most ancient one also. But even now, it is a very reliable criteria to effectively and accurately diagnose Parkinson disease is the UK Parkinson Disease Society Brain Bank criteria. So the cardinal
Yes.
features that I listed earlier, bradykinesia, that is the slowness, that is the most important factor that has to be there to diagnose a person as a Parkinson disease. It may be mild initially, but that factor is really important. And along with that, other factors like rigidity, which is the stiffness in the body, tremors, and postural imbalance, the way the person gets up, if he tends to fall again on the chair, or if he's not very stable while turning. So all these features, bradykinesia slowness, along with any of these three features, if it is present, then it raises a high suspicion of Parkinson disease. So Parkinson disease is also like many. There are many types of Parkinson disease. What we are talking about is the idiopathic Parkinson disease, which is most likely to respond to the medication. But then there are
The
other
one
group
which
of
doesn't
disorders
have any
also.
cause. Yeah, yeah. The one which has no cause, basically. Yeah,
No cause, yeah.
yeah.
So the other group of disorders which may mimic Parkinson disease but may not actually respond that well to the medication are called Parkinson plus syndromes. And we have to keep a lookout for these disorders as well, because they guide us as to how much medication or whether at all we should give medication to this patient or not. Or if we have to give, then how long do we give a trial and then conclude that it is not idiopathic Parkinson disease and it will not respond to the treatment. So generally
True.
in idiopathic Parkinson disease, we at the onset only we do not find any kind of memory disturbances or cognitive decline, whereas in certain kind of Parkinson plus syndromes we do find it. And then the other features like blood pressure fluctuations and all those things do not happen very early in the disease, but yes, when the Parkinson disease progresses, then these features are also seen. Then in Parkinson disease, early in the course of the disease, falls do not happen that commonly. But in the other group of disorders, which we call as Parkinson plus syndromes, falls are early feature. So these are the clinical hints in which we look out for to diagnose a patient as Parkinson
So
disease. But
overall,
generally,
you mean to say it is a clinical diagnosis, and sitting in my
clinical
clinic, I can
diagnosis.
say whether the patient has Parkinson's or not. what I see
Yeah,
in clinic, or you all also must have experienced that patients always do come and ask, do I need an MRI brain
exactly.
always to diagnose Parkinson's
Yeah,
disease? But I
yeah.
think it's
So
a clinical
radiology,
diagnosis more than an
yes,
investigation-based
yeah,
diagnosis. Of course,
yeah.
MRI is
So it
needed in some cases, which we will talk, but it's purely a
exactly, yeah.
clinical way to diagnose.
Yeah. So
True.
MRI does help. It is, but it is not required for the diagnosis. But it does help us in some scenarios where
In
there
certain
are some
group of
atypical features.
patients,
In
yeah.
certain group of
Yeah.
patients, we do require MRI just to confirm or just to like confirm our diagnosis. And then there are
True.
advanced modalities as well, which are available even in our hospital. The FDOPA scans
True.
and all. The group of disorders that you told about, Dr. Manish, was the drug-induced Parkinson disease. So to differentiate whether it is an idiopathic Parkinson disease or it is drug-induced Parkinson disease, and whether removal of the drug will itself cure Parkinson disease without requiring any other medication, can be confirmed by
True.
radiologic investigations like FDOPA scans, where the uptake of the tracer is checked, and then it gives us a hint that yes, it is actually a idiopathic Parkinson disease. So that's
True.
about diagnosis of Parkinson disease. So, Dr. Manish, I just mentioned that tremor is a very important feature of Parkinson disease. Usually, it is a rest tremor, and sometimes it becomes disabling also. Some Parkinson disease are tremor predominant, some are slowness predominant. But I want to ask you that all the tremors that come to our OPD, do all of them have Parkinson disease?
Yes, so a same question I face every day in my OPD. Any patient coming with tremors, the first question that he comes and asks me, "Do I have Parkinson's disease?" Because the fear and the worry in every patient's mind is that once somebody labels that Parkinson's disease, it's never going to get cured and it will keep on progressing. But I would take this opportunity to clarify that every tremor is not because of Parkinson's disease. So, as Dr. Ishu you have rightly said, that we need to see the other clinical features associated, like the cardinal feature among Parkinson's disease is slowness, what the patient comes with, and the rest tremor. That means if my hand is lying without any work and it starts trembling, or if my one finger starts trembling, if my thumb trembles, then yes, that rest tremor is because of Parkinson's disease. But if I get a tremor which is happening on doing some actions, if I'm signing a check and I'm getting a tremor, if I'm lifting a glass of water and getting a tremor, or my head is shaking, or if my voice is shaking, then definitely alternative diagnosis needs to entertain. This is not Parkinson's disease. Among the common things besides neurological disorders which can cause Parkinson's disease is anxiety itself. Coming to a hospital, seeing a doctor, getting worried. So anxiety can itself cause tremors. Thyroid disorders, hyperthyroidism can cause tremors. Patient who has asthma and is taking some inhalers or pumps, that itself can cause tremors. Some medications can cause tremors. So there are n number of causes besides a neurological disorder causing tremors. So when a patient walks to a clinic, we as doctors see the patient, take the history, look at the overall clinical picture, ask when the tremor comes. Is it along with slowness of activities? Is it one-sided tremor? Is it both-sided tremor? Is the head trembling? So many of the things we need to see before labeling a patient as Parkinson's disease, because once you label somebody as Parkinson's disease, then it's a long-drawn course. Patients are exposed to medications, long follow-ups, which may not be required if I find out an alternative diagnosis. So many of the things need to be kept in mind before saying that this is a tremor because of Parkinson's disease, because that is the main thing which the patient comes in. मेरा हाथ हिलता है, मेरे को Parkinson's है क्या? That is a question every day I face in my OPD, and I'm sure my colleagues also must be seeing that question arise, and they need to answer that, and we have to be very careful when we are telling that somebody has Parkinson's disease.
And many a times we see that it is not actually a Parkinson tremor, and the patient has already been
Exactly.
started on the drugs without any
Right.
benefit to the patient,
Right.
but experiences side effects because of the same.
So, history start when it's happened. Is the patient on some other medications? Is he has some other medical problems? All that need to be found out before we just label a patient as Parkinson's disease. So, Dr. Ishu, I would like to ask you that, okay, once I confirm that my patient has Parkinson's disease, what other complications that the patient may face, or the associated problems or additional problems he or his family may face, along with whatever you have very nicely described as tremors and also, what other problems do I explain to my patient or anticipate?
Yeah, so I'll take up this question into two parts because these are very two important aspects. One is the complications, and other is the additional features. So sadly, additional features are very less recognized and very less addressed even in the OPD settings, because the primary complaint of the patient is a motor complaint where he's not able to walk, or where he has a significant disability. But in our busy OPDs, we often forget to address other complications, other additional features that the person suffers 24/7. He might not, in his anxiety, he might not be able to tell you, or might forget to tell you in the OPD. But these are significantly, they cause as much disability and as much discomfort to the patient as the motor symptoms cause. So the additional features associated with Parkinson disease are, first feature is the constipation, GI disturbance, and we see that the elderly already, they have a lot of GI problems, gastrointestinal problems. And if a person has Parkinson disease, then more often he also has constipation associated along with the motor features. Then the second problem is the sleep disturbance. So Parkinson disease is very frequently associated with REM behavior disorders, which means that a person tends to enact his dreams. A person, if he has that dream that he's running, or a police is chasing him, or he's shouting, then he tends to fling his arms and legs while in sleep. He might even try to get out of the bed, and many a times people do get injured. They just jump out of the bed and not knowing that they are falling, and they severely hurt themselves or their partners also, because the flinging is such violent that if a person punches the partner, we often do get that scenario, that these kind of behavioral, these sleep disturbances are very commonly associated with Parkinson disease. Then,
True.
as the disease progresses, Parkinson disease is also associated with gradual loss of cognitive functions. The memory tends to decline, the attention span tends to become very less, and the slowness that we see in the movements also comes in the thinking process. The time taken to respond to any kind of question keeps on increasing as the severity of the disease increases. Then, as the disease progresses, there are a lot of autonomic disturbances as well. By autonomic disturbances, I mean that there are gross blood pressure fluctuations. A person, when he gets up, he might feel giddy because of the drop in blood pressure. And giddiness is such a vague term and such a commonly used term that we have to discern that this giddiness is what kind of giddiness, whether it is spinning of head, whether it is because of drop of BP when the person is standing. And then there are urinary problems. As it is, we deal with the elderly population, which have a lot of urinary frequencies, urgencies, and all the more so if the person is suffering from Parkinson disease. And then comes
True.
the mood fluctuations, which the person has, and the family members suffer more because of that rather than the patient himself. There are gross, the person may become withdrawn, depressed, he might not want to participate in anything. As it is, the disease is disabling in advanced stages if not very well managed, of course, and the mood fluctuations further add on to the poor quality of life that may be there if not adequately treated. This was about
True.
the additional non-motor problems that have to be addressed and actively asked by all the physicians to the people coming with Parkinson disease, whether or not they come out with these problems on their own or not. And then comes the complication part. So, if we talk about the complications of Parkinson disease, I would further divide it into two. One is the disease related complication. As the disease progresses, I have already listed some of the complications, but then if it is not adequately managed and the medication titration is not proper, then the person keeps on becoming slower and slower to an extent that he might require two people support to walk, or he might not be able to walk at all because of that. And this motor disability keeps on increasing and accumulating over years and years altogether. But then the good news is that Parkinson disease is also variable. It might not be so disabling in some people, it may be very slowly progressive in some, and it may leave a person disabled over a few years only in some cases. So that only time tells that how the Parkinson is going to behave in a one particular person. And then when we treat with the medications, the dose of the medications keep on increasing over the years as the severity of the disease increases. And after a few years, the side effects of medication also comes. The movements that we were trying to facilitate, they may become out of control, and may lead to loss of postural balance in the patient, and the patients may also suffer fall because of the medications. but then we are left with no other option, because if we give medication, then these abnormal movements happen. If we don't give, then the person becomes totally immobile. So the titration has to be very, very gradual and over a period of time, so that we can use the drug for as long and as long duration as possible. So these were some of the complications related to the disease, related to the medication, and the associated problems that Parkinson patients generally suffer from.
True.
So I have just touched upon briefly on the medication part. I would request Dr. Manish to elaborate on how do we treat Parkinson disease patient, and how do we titrate, and how well the disease gets controlled once we start with the medication.
Yeah, so once we diagnose the patient as Parkinson's disease, as we are speaking about the common variety, which is the idiopathic Parkinson's disease, uh, based on the age group, there are a lot of medications that are available. If the patient comes at a relatively younger age, by relatively younger age, I mean in the 60s or 55, 60s, then we use a medication which are called Syndopa or L-Dopa sparing medications, where I give a certain group of medications which helps the cells to release the remaining dopamine which is there in the brain. By doing that, I'm keeping the main medication towards the end, where I need that main medication, which we call L-Dopa, which is the dopamine which you're giving externally in the form of tablet. So based on the age group, based on if the patient has more tremor, is he has more slowness, he has walking difficulty, I decide the class of medications that is to be used. I start with the minimum possible medications, and whatever these medications I'm speaking about to start with are symptomatic medications. They will reduce the symptom of the Parkinson's disease. There is no medication available till date which will cure the Parkinson's disease or stop the process of the neurodegeneration which is happening in the brain. These medications, what I'm talking about, will treat the symptoms. As time goes, the doses of medications, as you have rightly suggested, will keep on increasing based on how the patient tolerates the side effects. I need to keep titrating the medication, the combination of medication. Like if the patient just comes to me with rest tremor, I may just give a tremor medication. If he comes with slowness of the activities and tremor, then accordingly I will choose a combination of the medicines. Then if the patient has associated risk factors, accordingly I'll choose those medications. So the medications keep going up, the doses keep going up gradually, and that this will vary from patient to patient. In some, it may take months and years. They may be on constant dose of medications. I have some patients who are on very, very low dose of medication and they are doing very well. But in some, the disease process is quite rapid. Like if I have a patient who has multiple other vascular risk factors like diabetes, hypertension, and all, which itself affects those brain areas from where these dopamine and these chemicals are released, his progress of Parkinsonism will be faster. He may need higher doses of medications in the coming months. So that is how it's basically a symptomatic treatment. As far as cure is concerned, there are lots of research and trials going on. Some medications have been tried in the past, but they have not shown any efficacy. So if I put it in simple word, there is no cure for a neurodegenerative variety of Parkinson's disease. It is symptomatic treatment as far as medicines is concerned. Of course, there are other options of treatment which we will be discussing subsequently. That if the medications don't work, then what do we do? Coming to the other variety of Parkinson's disease, which we said where we have a cause like tardive Parkinson, where it's a drug induced. So when I know that this patient is taking the drug, the first step will be to stop the medication and see whether his symptoms improve or not, and then along with that give the medication which I just spoke. So if I have a cause, I will try to remove the cause. But if I don't have a cause and I know it is a neurodegenerative variety or idiopathic Parkinson's or a atypical Parkinson's of late onset, then it is symptomatic treatment. Along with treatment, what other important thing is rehabilitation, the physiotherapy, the gait and balancing exercises, because Parkinson's patients and these elderly patients keep falling and they keep coming with injuries to the hospital, head injuries, fractures. So what I tell my patient always in the clinic is, yes, I'm giving you medications, that is part of the treatment, but along with that, you need to keep doing physiotherapy, gait and balancing exercises, wear proper footwear, use a walking aid. If there is nobody at home to help you to walk or hold your hand, you take a stick and walker to walk. I don't want to see my patient coming in the emergency with a head injury or a fracture because of Parkinson's disease. So rehabilitation is a very, very important aspect of treatment of Parkinson's disease, and that helps in maintaining the quality of life, and that avoids secondary problems what these patients face. So medications and rehabilitation are a very important part of the treatment of Parkinson's disease. And the subsequent aspect, as we'll be talking now, and it would be my pleasure to ask Dr. Vivek Agarwal. Uh, Dr. Vivek, if my patient has reached to an optimal level of Parkinsonian medications and he has started developing side effects, like if I'm giving Syndopa or L-Dopa in very high doses and he doesn't tolerate, if I reduce the medication, he has slowness of movement. If I increase the medication, he starts excessively moving. So in that case, we all will need your help. And can you tell us about the surgical treatment of Parkinson's disease? And once I tell somebody as that he has to undergo surgery, then the thing comes whether my insurance will cover this surgery or not, or whether I have to pay out of my pocket. So can you please enlighten us on this aspect of treatment of Parkinson's disease?
Thanks, Dr. Manish. So actually, the treatment of Parkinson started with the surgical treatment only. So in very beginning, all the Parkinson patients, they were treated by neurosurgeons by doing various neuroablative procedures in basal ganglia. But with the advent of the new drugs, as you all discussed, levodopas and other medications, the results were so fantastic that now without any surgery, patients were getting good relief. So over a period of times, the role of surgery was diminished and it was almost stopped. But gradually, people realize that after giving medication for few years, these patients they again develop problem. They develop on and off phenomena. They develop motor fluctuations. So the problem recur again, and they don't get that much of benefit as they were getting in beginning part of their treatment. So that results in re-emergence of surgery. So after that, the people started, neurosurgeons started working on this, and they tried finding other way to support these patients at this stage when the patient start developing motor fluctuations, or at very high doses of medication they start getting side effects. Basically, surgery in Parkinson is there are two kind of surgery we are doing at the moment. One is neuroablative lesioning procedures. So neuroablative lesioning procedure, the problem with it is that you do one time either thalamotomy, pallidotomy, or subthalamotomy. The results of these procedures are also good, but the problem is that these are non-adaptive and there's no reversibility. So once you make lesion deep inside the brain with the electrodes, you cannot change that. If the patient is getting good results, very good. If he's getting some side effect or you want to increase stimulation or change it, you cannot do. That's the advantage we get with the deep brain stimulation. So nowadays, the preferred method of doing surgical procedure in these cases where patients are not getting optimal relief with medications are deep brain stimulation. So what we do in deep brain stimulation is that we place a lead deep inside the brain and we connect the other end of the lead to a battery which is placed here just below the collarbone. And high frequency electricity is passed through with the help of the battery or IPG into the deep inside the nucleus. So that stimulation inhibits the bad functioning neuron nearby that electrodes and helps to improve function in the Parkinson patients. As your second question regarding insurance, yes, so the DBS was approved in 1997 for doing unilateral DBS procedures and in 2003 for bilateral by FDA. So it is well approved method of managing the advanced cases of Parkinson, and more than 150,000 cases has been done across the world, and in India almost more than 500 cases are happening every year, and it is well covered by all the insurance companies. So the patient or relative don't need to be worried about whether it is covered by insurance companies. So it's well approved and covered by insurance companies.
So, Dr. Vivek, how do you perform the DBS surgery and what are the risks involved?
So DBS surgery. So in general, these patients need to be admitted in hospital almost for a week. A day prior to surgery, when we are going to perform the surgery, we need to admit the patient and do all pre-operative workup. And before that, whether that patient is fit for DBS surgery or not, that whole DBS surgery team decides. That I will discuss with Dr. Ishu later. But intraoperative portion, how we do, I'll let you know. So during surgery, what we do, a day prior to surgery, we admit the patient. We do a special protocol of MRI, and day prior to surgery, we stop all the medications of Parkinson's so that we have a patient where all the symptoms are evident on table while doing the procedure. On the day of the surgery, first thing we do in morning, we apply a frame over the head of the patient under local anesthesia, and we shift this patient to CT scan for doing a special CT. And once CT is done, the whole procedure is divided in two stages. Stage one, which is done under in awake state, where patient is awake, and because patient assistance is very very important during procedure, because we check his whether the patient is improving in its symptoms or not on table, at the same with the recording of electrodes, and if patient is unconscious, we cannot check because even a minor change, a few millimeter change in the position of the electrode can result in a huge difference in outcome. So first stage is done in awake state, and the second stage, which is the battery placement or IPG placement, is done under general anesthesia. So once CT is done, we shift this patient to OR, and we make a two small hole in the frontal area, one by one, and we place these devious lead deep inside brain with the help of special frame that is called stereotactic frame. And while placing these leads, we check the clinical function of patient, wherein our neurologist, Dr. Ishu, help us so that we are examining the patient's function. We are checking whether tremor is getting relieved or not, how is the rigidity, how is the bradykinesia. So the position where we are getting the good result, that is the final position, and we leave lead at that point. Once it is done on one side, we perform the same thing on other side, and once the lead placement is done on both the side, we shift the patient back to CT for doing the procedure, checking whether lead placement is correct or not. CT once shows that the lead placement is optimal, it is right in place, we shift back this patient back to OT, and we give general anesthesia. So whole this process of placing the lead, it takes almost 4 to 5 hours. If our patient is cooperative, and if we feel that we can perform the second stage, we can do both the procedure on the same day. But because we have stopped syndopa of the patient a day prior, many a time these patients they don't cooperate that much. So in those cases, we have to stage out. So stage two, sometime we do on the next day or maybe at a later date. But majority of cases, what we are doing here, we manage to do on the same day. So once the lead placement and we have confirmed that the lead is in optimal place, we shift back this patient to OR, and we give general anesthesia to the patient, and we place IPG or battery of the patient here just below the collarbone. We make small pocket here, and this is a very small battery which we implant similar to like a cardiac pacemaker. And then we connect these leads to battery. We don't start pacing immediately after the procedure, and we shift these patients to ICU for observation. So none of the surgical procedure is without complication, as you rightly asked about the complication related to this procedure. But overall complication risk in this procedure is very low. As I told you, the major portion of the surgery is done under awake state. The risk of general anesthesia anyway is reduced in this procedure. Second thing, compared to other neurosurgical procedure like brain tumor excision and other major neurosurgical procedure, the complication chances are very low. It is almost from 1 to 3%, and the majority of complications which happen are manageable with medication or it reverses over a period of time. Some of the major complications are like trackside bleeding. The bleeding happens whether you are placing the lead. Can say second thing is there can be a migration of lead or fracture in lead. So these are the some rare complications, or seizure. These are the some rare complication. In some of those complications, we can manage it with the medication and conservatively, but in few cases we need to take out the implant and re-perform the same surgery or lesioning surgery at a later date.
True.
So, Dr. Ishu, can you tell me, do you feel all the patients of Parkinson's we can perform surgery, or there are specific group of candidate where surgery works and we should propose doing surgery, devious surgery in those patients?
Yeah, that's a very important question because the emphasis that we give to the intraoperative techniques and the expertise of the surgeons, which fortunately we have a very good surgeon, Dr. Vivek, with us, in whom we have full confidence that he is expert at it. The same emphasis lies on the proper patient selection because we would not want any of the patients to be subjected to a surgery where the chances of giving him benefit is less than the risk involved. So the patient selection is very, very important. And when a person comes to us and we think of a candidature for DBS surgery, we think of two things: whether the person is idiopathic Parkinson disease, whether he fulfills all the criteria, and whether there are any red flags uh, that are the contraindications, that even in spite of the fact that he is an idiopathic Parkinson disease patient, but he should not have any of the associated contraindications or the red flags which may make him not eligible for DBS surgery. So, a typical candidate for a DBS surgery would be any patient with idiopathic Parkinson disease, but in whom we have been treating him over 5 years. So, this 5 years period we take to ensure that he is responsive to the medication, because we see that whatever benefit we get out of DBS surgery, whatever symptoms he had earlier, be it slowness, be it tremors, they respond only when they have responded earlier to the dopaminergic medications that we were using. Some features like gait disturbances, which sometimes respond to the drugs, sometimes they do not. So these features, which were not initially responsive to the medication, are unlikely to respond even after the surgery, to the surgery also. So selecting a patient is important in the sense that after 5 years we are sure that this patient is idiopathic Parkinson disease, he is responsive to the medication. And when the person starts showing side effects or motor fluctuations like the on and off phase we talked about, he's taking the medication but the effect is not coming for half an hour, 1 hour. Even after taking medication for 1 hour, the patient does not feel any relief. The medication works only for 1 hour. Then how frequently can we tell the patient to take the medication? The patient cannot take the medication every hour. So the duration for which the medication is working becomes very less, or side effects start coming where we talk about the abnormal movements, dyskinesia start happening, which make the person unstable. In such scenarios where the patient develops motor fluctuations secondary to the medication, but he does show response to the medication, these kind of patients are the ideal patients where we suggest that now is the time that you go ahead with the surgery. So this is the absolute indication. Then there are certain red flags where we have to think about. They are basically to exclude patients who are not idiopathic Parkinson disease. So we look for cognitive decline, whether at all there is a significant cognitive decline, dementia in the patient. So, if the patient has a significant dementia, that only becomes a contraindication because it is an awake surgery. We need patients' utmost cooperation during the surgery so that he can tell us that whether he is feeling any relief by lead placement or not. If the patient has cognitive decline, he cannot analyze the situation properly, then he will not be able to help us during the surgery. So because of that, if we feel that the person has significant cognitive decline and he will not be able to understand that whether any change is happening or not, so that in those cases we do not encourage the surgery to be happening. And the other indications, like I listed earlier, the Parkinson plus syndromes, they are the efficacy of DBS is still not established in those cases, and we make sure that we exclude all those group before we ensure that the person is fit to go ahead with the DBS surgery. The other group of patients are the young Parkinson disease patients because they have a very long lifespan to look forward to, and the disease generally starts around 40s, in the early 40s. So they have at least like 30-40 years to look forward to. So in those cases, we know that we will not be able to give them dopaminergic drugs for this long duration, and they will definitely develop side effects at a later date. So we encourage early surgery in such kind of patients so that we can give them a life with good quality at an early stage rather than waiting their condition to get deteriorated and after that we suggest them for the surgery. So these kind of patients, the young Parkinson disease and the typical Parkinson disease patients with motor fluctuations without any significant contraindications, are the group of patients that we offer DBS surgery in. So the cutoff, there is no particular cutoff as to till when we can do the DBS surgery, it is just relative. So generally, approximately like 70 years, till 70 years, we, if the patient satisfies all the criteria, we do not think about counseling the patient regarding the age factor. But age is not a particular cutoff for excluding a patient, and DBS surgeries are carried out even in patients who are 75, 80 years old with good results. Yeah. So, Dr. Vivek, you talked about the immediate risks that were involved in the surgery. What about the post-op care of the patient, like immediate post-op care, immediately post-op, what things do we take care about? And what are the later post-op care that we have to take in the patients? Please enlighten us on that.
Okay. So the major thing immediately after surgery is that we have to take care of the surgical site. We should not put anything like a water or scratch the surgical site to prevent any infection happening at the surgical site, because infection happening at the DBS site has a bad, it's a bad problem. Giving antibiotics sometimes doesn't work, and then you may require to take out the whole implant. So taking care of the surgical site is very important. Apart from that, we permit traveling 1 month after the surgery to all these patients. Patients can start doing sports activity like walking, jogging, swimming. But extreme sports activities, it is not allowed because it can cause change in the lead placement or it can damage the battery. So extreme sports are contraindicated in these patients. Patient can travel by flight after a month after the surgery. Routine diagnostic procedures like ECG, X-rays, or any other like sonography, mammography, all are permitted after doing this procedure. But MRI is contraindicated because MRI creates a strong electromagnetic area which can interfere uh, in the setting of this deep brain stimulation device. So MRI is contraindicated in DBS, but yes, if it is dire situation in strict protocol with the strict protocol, even MRI can be performed. We ask all these patients to avoid going close to strong electromagnetic area because that can damage the device. It can change the programming, which can result in the dysfunction of the DBS device. So, like going close to metal detector in malls or at airport, going close to theft detector or MRI machine is contraindicated in these patients. These patients should always carry their card, and if they are going somewhere where the metal detector is being used, they should show their card and they should check their security check manually rather than passing through metal detector. Apart from that, whenever these patients are going for any intervention or surgery for other than this Parkinson for any other reason, they should always contact DBS team because there are many things which are not known to people and that can result in the problem in the DBS device. So one of the example like monopolar cautery. Monopolar cautery is used for stopping the bleeding during any surgery. It is contraindicated once patient have DBS device in place. So these things has to be take care while the patient is living life with the DBS device in place. So one more thing I want to tell you that these DBS devices are two varieties. So one is the non-rechargeable and another was rechargeable DBS. So non-rechargeable DBS, you don't need to charge, you don't need to do anything, and the shelf life of these batteries are from 3 to 5 years. You don't need to do anything during these 3 to 5 years, but they should be aware about that after 5 years, there will be a need of changing the battery. The other one where we are putting the rechargeable one, that shelf life is 15 years. But in those cases, patient or relative has to charge the battery every 7 to 10 days. It takes 45 minutes, and one has to put a wireless charger over the IPG or battery. It takes 45 minutes for battery to full charge, and it works for 7 to 10 days. But during whole process during the whole follow-up period, you have to be in touch with your deep brain stimulation team because they will be keep checking the life of the battery, the status of the battery, how is the things are happening. They patient may require programming later on or titration of doses because all things are important for optimal result in DBS cases.
So you
So Dr. Ish,
mentioned something about
yes.
being like it. being similar like cardiac pacemaker. So is it exactly the same device, or there are certain differences, or like how do we make our listeners understand that how is it different from cardiac pacemaker, or how is it similar?
So functionally, actually, both the devices are same. In cardiac pacemaker, cardiologists place the leads through the vein into the heart, and that cause pacing of the heart. Other end of the lead is connected to pulse generator. Same like DBS. Here also, though this is technically more demanding, here we place the electrode right into depth to the brain, and then other end is connected to pulse generator. So more or less, both the devices are same. Like cardiac pacemaker, here also we need to change the battery after a gap. The battery setting and programming can be done same like a cardiac pacemaker. So yes, functionally and placement wise, everything is more or less same like a cardiac pacemaker. Yes. So, Dr. Ishu, can you tell me that once we have done DBS implantation, what is the expectation? I mean, generally, the patient has expectation that after we have placed the DBS, the patient will improve immediately. We will stop medication completely, and will patient will start walking. All the problems which was there, shakiness or difficulty in movement, slowness in movement, will resolve immediately. So, what is a practical outcome in these patients after DBS placement? What is your experience, and how often you call these patients so that they need to come to DBS team for follow up to have a good results?
Yeah. So before sending any patient for the surgery, we just make sure to meet their expectations and clarify all the doubts that they have. And this is a very common doubt that we come across. The expectations are like it is like a tumor surgery where we'll remove the tumor, and the person will be absolutely fine. He'll not be having any symptoms in future. But this is not so. Although DBS is magical, but the magic does not happen with a drop of a hat. It takes a lot of time, perseverance on the part of the patients, on the part of the doctors, for adequate titration between the doses and the current settings. And it may take from a few months, and sometimes it may take an year also before that optimal setting is reached, where the person becomes independent, functional, and our target always remains to make the person independent, to improve the quality of life by approximately 50 to 70%, and to make the person independent by 70% in all his activities of daily living. But we never promise a patient, and we never ensure the patient that he will be absolutely off medications. Like if the patient is on 14 medications or 13 medications in a day, we tell them that the dose required post surgery would reduce by approximately 60%. And now if he's taking a cocktail where he is just sipping the medicine dissolved in water to remain free of the symptoms throughout the day, from that level we will bring him to at least 3 to 4 tablets in a day. And if the DBS works out very well for the patient, then maybe 2 to 3 tablets in a day. But we never promise the patient that the patient will be off medication ever. But there is a significant reduction in the amount of medication that the patient has to take, and the side effects that were there because of the medication, they also drastically go away after the person undergoes DBS surgery. So these are the expectations that we clarify before a patient undergoes the DBS surgery. And regarding the programming, initially after the surgery, after 2 weeks, is the first programming session that we do. In that, because when the surgery is done, there is a swelling, local swelling around the area, which is called lesioning, which itself gives a stimulatory phenomena to the patient, and the patient is walking fine and talking fine even without the medication. So that is the effect that the DBS has, and they feel that this is going to be permanent. But then we clarify that it is not going to be permanent. Once the swelling goes down, he may require the initial amount of medication. We cannot directly switch it on and keep it in the maximum current range, because then it has its own side effects. So we gradually go up in the current settings. So the first manipulation of any of the current is done 2 weeks. Generally, it varies with the person to person, whoever is the neurophysician. But generally, we do it after 2 weeks. So we check all the sites where the current may be working, and how much current stimulation is giving the person maximum benefit without causing any side effect. First, we detect that area, and then gradually, step by step, every 2 weeks or every month. We keep on increasing till the time the patient becomes absolutely comfortable and there are no side effects as well. And simultaneously, we keep on going down on the medication. So it is a very gradual process of titration, and there has to be a lot of patience and a lot of understanding between the doctor and the patients that this works over time. But yes, it does work when the patient selection and the surgery goes out well. It does work, but it takes time for that optimal effect to be attained. So these
So,
are the main benefits. Yeah.
true. So, Dr. Vivek and Dr. Ishu, can you tell us what are the benefits of DBS? Does all the symptoms of DBS with the DBS go away, or what do I tell my patient?
Yeah, so post DBS, as we discussed, that after few years of medication, these patients develop motor fluctuations. They have on and off phenomena. Then after you give medication, they have effect for few hours and then go in off phase where the patient have again slowness, tremor, and other problems. After doing DBS, the duration of this on phase it increases significantly. Like patient having on phase for 1 hour, it increased to 8-10 hours or more than that, and even the disability during off phase comes down. So there are significant improvement, but it is not like completely 0% problem. So on phase duration increases, severity during off phase also comes down. As Dr. Ishu told that the medication doses of medication comes down significantly, like for 40 to 50% doses comes down. So all the side effect related to medication that also comes down significantly after DBS surgery. So all like a hallucination happening because or dyskinesia happening because of the medication, that those also comes down significantly after doing DBS surgeries. Some of the tremors are resistant to medication. They are refractory tremor that doesn't respond to treatment. That also respond well to DBS, and that also significantly comes down in almost 70 to 80% of the cases. There are
Right.
certain non-motor benefit of DBS also, like it reduces pain, it reduces sadness, and it improves the sleep quality in Parkinson patients as well. But there are certain areas where DBS doesn't work. I will request Dr. Ishu to discuss about the non-motor benefit or areas where it doesn't work after placing the DBS device.
Yeah. So I mentioned earlier that the symptoms that had earlier responded to the medication, they are the best to respond even after the surgery. So those are our target symptoms, and we carefully look at the patient and identify what is the most common symptom, what is the most disabling symptom in this patient. If it is pertaining to only walking, like freezing is happening, or there is gait instability. Freezing still responds somewhat to DBS if it was responsive to dopamine earlier, but if there is instability, it generally does not respond that well to DBS surgery if it was not responsive to medication earlier. And moreover, regarding the non-motor symptoms, another reason for not selecting dementia patients for DBS surgery is that after carrying out DBS surgery, the dementia may even worsen. So, in patients where we have significant cognitive decline, this is another reason why we avoid doing DBS surgery, because cognition may get affected. Then, according to the lead placement, because it's a very narrow and very small area, you can just imagine a few beads placed around each other, and whenever we are stimulating one bead, it is stimulating the rest of the area surrounding also. So if the current is not properly manipulated, it may lead to double visions, and all those things have to be looked after properly. So these are the things that we should be looking out for regarding the symptomatology and after doing the DBS surgery.
Right. Great. So, Dr. Ishu and Dr. Vivek, it's always said that prevention is better than cure. So, Dr. Ishu, can you tell that is Parkinson's disease preventable?
If we ask in yes or no, we cannot classify it as yes or no. But yes, definitely, Parkinson disease is preventable to a certain extent. But these modifications have to be done in general population. No, even after detecting with early Parkinson disease, if you make significant lifestyle changes, the worsening may be slowed to a significant extent, and the symptoms that you might be having, they may be like 50% managed by lifestyle modification. but it is not entirely 100% preventable. If a person is bound to have Parkinson's disease, he would eventually get it, but at least we are able to delay the onset of Parkinson's disease and reduce the severity. So by lifestyle modification, two things come to our mind. One is the dietary modification, and one is regular physical activity, which has been a very important factor in our life, which is modifying many of our diseases like blood pressure, dementia, all of these things. So regarding the diet, Mediterranean diet is listed as one of the best diets. In Mediterranean diet, we aim to take good fatty acids, not saturated fatty acids, not saturated fats. So omega 3, omega 6 fatty acids that are found in abundance in salmon, fish, the studies say that they are very effective and beneficial in preventing Parkinson disease. In people who are vegetarian, who do not consume fish and all, almonds and diet rich in free radicals like nuts and berries, and all the diet rich in these antioxidants, they are very effective in preventing the Parkinson disease. In Indian diet, fortunately, turmeric is a very important constituent which is used day in day out in most of our food items. Abroad, this turmeric is given as a tablet, but fortunately we use it day in day out. So it is also very helpful in preventing Parkinson disease. Simultaneously, it is seen that excessive dairy products, especially cheese, should be avoided in people who are predisposed to get Parkinson disease or who have already manifested with the symptoms, because they have certain essential chemicals which antagonize the effect of dopamine. So excessive dairy products, eggs, cheese, and even soya bean, because it has a lot of manganese, which again interferes with the functioning of dopamine. So these things should be avoided in diet. And regarding physical activity, it should be a regular aerobic physical activity, because it increases the blood and oxygen supply to our brain as well, and hampers or slows down the neurodegeneration that is happening in the brain. And it has been seen that cycling in the early stages of Parkinson's disease, of course, if your knees allow it, but cycling is a very effective measure to maintain your balance, because it is mainly what happens in Parkinson's disease is the synchronization between the brain and the hands and legs go away. The rhythm goes away. So it is always said that in patients with Parkinson's disease, you keep on playing music in the background so that the rhythm that you have lost from inside is given to you from outside. But before it is lost, it is helpful to maintain coordination by doing regular physical activity, then particularly focusing on coordinating activities. Your physiotherapist might help you in that. And cycling maintains that rhythm. It continuously gives you the brain that signal that the legs have to be moved in a synchronous manner, and then that becomes a subconscious process which helps you to walk in a stable manner for a very long time. Then, as Dr. Manish has in detail elaborated about the drugs, we should identify whether we are consuming any such drugs which may be predisposing us to the Parkinson disease and stop them at the earliest. And then the pesticides and insecticides, if there are any other additional chemicals that may be predisposing us to Parkinson disease, those have to be identified and eliminated. So grossly, this is the prevention of Parkinson disease, and we should be really, really very watchful about it.
So maintaining a healthy lifestyle, diet, exercise is a very, very important, as we see in many chronic diseases across organ systems. So it was a great and enlightening and a very fruitful discussion that we have, and definitely I think it will help our audience and whoever is listening and attending this to identify what is Parkinson's disease. So I thank you all for taking out your precious time this afternoon and attending this discussion on a very important neurological disorder called Parkinson's disease. I thank my esteemed colleagues, Dr. Vivek Agarwal and Dr. Ishu Goyal, for taking out their precious time and enlightening us on this very important disorder. Thank you very much. Have a great afternoon and a great day.
Thank you.
Thank you so much. Thank you. Thank you, everyone.
Thank you.